Welcome to the American Academy of Sleep Medicine Clinical Practice Guideline webinar series. This webinar will review the 2019 American Academy of Sleep Medicine Clinical Practice Guideline on the treatment of adult obstructive sleep apnea with positive airway pressure. During this webinar, we will review the reasons for this guideline update, the methodology employed, good practice statements adopted from previously published guidelines, the clinical practice recommendations and associated remarks, and future directions. Since the publication of the previous American Academy of Sleep Medicine Positive Airway Pressure Practice Parameters, the scientific literature has continued to expand regarding the effects of PAP on clinical outcomes in adults with obstructive sleep apnea. In addition, research on improving PAP adherence and advancements in device technology have continued to evolve, justifying the need to update the guidelines. The research questions developed for this guideline were designed to identify optimum device modalities and configurations by which PAP may be reliable. This guideline combines and updates information from 3 prior guideline documents: practice parameters for the use of continuous and bi-level positive airway pressure devices to treat adult patients with sleep-related breathing disorders, published in 2006, clinical guidelines for the manual titration of positive airway pressure in patients with obstructive sleep apnea, published in 2008, and practice parameters for the use of auto-titrating continuous positive airway pressure devices for titrating pressures and treating adult patients with obstructive sleep apnea syndrome, an update for 2007. The American Academy of Sleep Medicine commissioned a task force of board-certified sleep medicine physicians with expertise in the treatment of adults with OSA to develop the guideline. Clinical questions were developed based on a review of the existing AASM practice parameters on the use of positive airway pressure for the treatment of patients with OSA, and an assessment of systematic reviews, meta-analyses, and guidelines published since 2006. The questions address commonly used positive airway pressure device modalities and configurations versus a comparison therapy for the treatment of adults with OSA. Based on their expertise, the task force developed a list of patient-oriented, clinically relevant outcomes that are indicative of whether various forms of PAP treatment should be recommended for clinical practice. A systematic review of the scientific literature was performed to identify relevant articles that addressed at least one of these clinical questions. The task force extracted data from accepted articles, and meta-analysis was performed on clinical outcomes of interest when possible. Clinical significance thresholds, used to determine if a change in an outcome was clinically significant, were defined for each outcome by task force clinical judgment prior to statistical analysis. The task force then used the grade system to assess the evidence and determine their certainty that the scientific literature was reflective of what the average patient would experience, referred to as quality of evidence in the guideline. Next, the task force considered the balance of beneficial and harmful effects of each intervention, and the patient values and preferences and costs associated with each intervention. Based on these criteria, clinical practice recommendations were developed and assigned a strength of recommendation. The task force also developed good practice statements based upon recommendations included in previous practice parameters that the task force felt were important to include in this guideline. The strength of a given recommendation was designated into one of 2 categories: strong or conditional. A strong recommendation implies that almost all patients should receive the recommended course of action. Such recommendations could be used to develop performance measures. A conditional recommendation reflects a lower degree of certainty in the appropriateness of the patient care strategy, requires that the clinician use their clinical knowledge and experience, and strongly considers the individual patient's values and preferences to determine the best course of action. Ultimately, judgment regarding any specific care must be made by the treating clinician and the patient, taking into consideration the individual circumstances of the patient, available treatment options, and resources. The task force adopted 2 good practice statements from previously published practice parameters. The task force deemed the implementation of these statements necessary for appropriate and effective diagnosis and management of OSA. The first good practice statement is, treatment of OSA with PAP therapy should be based on a diagnosis of OSA established using objective sleep apnea testing. This good practice statement applies specifically to a new diagnosis of OSA, which should be established by either a home sleep apnea test or in-laboratory sleep testing prior to initiation of treatment for OSA. Patients with a previously established diagnosis of OSA who are currently on PAP therapy and have good symptom control should continue PAP therapy, even when prior testing results are not readily available. The second good practice statement is, adequate follow-up, including troubleshooting and monitoring of objective efficacy and usage data to ensure adequate treatment and adherence, should occur following PAP therapy initiation and during treatment of OSA. Periodic follow-up by a qualified clinician, for example, physician or advanced practice provider, is necessary to confirm adequate treatment, assess symptom resolution, and promote continued adherence to treatment. Initial treatment of OSA requires close monitoring and early identification of difficulties with PAP use, as adherence over the first few days to weeks has been shown to predict long-term adherence. Objective monitoring of PAP therapy should be performed to complement patient reporting of difficulties with PAP use, as patients often overestimate their use of PAP treatment. The task force developed a series of recommendations upon completion of the evidence review. Recommendation 1 states, we recommend that clinicians use positive airway pressure, compared to no therapy, to treat OSA in adults with excessive sleepiness. This is a strong recommendation. This recommendation is based on 38 studies that assess the efficacy of PAP to reduce the critical outcome of excessive sleepiness. Meta-analysis of these studies demonstrated a clinically significant improvement in sleepiness with the use of PAP to treat adults with OSA as compared with no treatment. The quality of evidence was considered high. While a benefit of PAP use includes a reduction in daytime sleepiness, the potential harms include side effects such as nasal dryness or irritation, dry mouth, sore throat, and sinus infection, as well as loss of intimacy, all of which can be mitigated with appropriate interventions or are reversible with discontinuation of PAP. The task force determined that the potential benefits of PAP therapy outweigh the potential harms and that the majority of patients would favor its use. Recommendation 2 states, we suggest that clinicians use positive airway pressure, compared to no therapy, to treat OSA in adults with impaired sleep-related quality of life. This is a strong recommendation. Sleep-related quality of life in adult patients with OSA may be adversely affected by OSA-related symptoms. Examples of such symptoms include snoring, sleep-related choking, insomnia, disruption of bed partner sleep, morning headaches, nocturia, impairments in productivity or social functioning, and daytime fatigue. This recommendation is based on 19 studies that assess the efficacy of PAP to improve the critical outcome of sleep-related quality of life. Meta-analysis of these studies suggested potential for clinically significant improvement in sleep-related quality of life. The quality of evidence was considered moderate. While a benefit of PAP use includes an improvement in sleep-related quality of life, the potential harms include side effects such as nasal dryness or irritation, dry mouth, sore throat, and sinus infection, as well as loss of intimacy, all of which may be mitigated with appropriate interventions or are reversible with discontinuation of PAP. The task force determined that the potential benefits of PAP therapy outweigh the potential harms and that the majority of well-informed patients would choose the intervention over no treatment. Recommendation 3 states, we suggest that clinicians use positive airway pressure, compared to no therapy, to treat OSA in adults with comorbid hypertension. This is a conditional recommendation. This recommendation is based on 5 studies that reported on the efficacy of PAP therapy on the critical outcome of blood pressure in this patient population. Meta-analysis of these studies demonstrated clinically significant blood pressure reductions in nocturnal, daytime, and 24-hour systolic and diastolic blood pressure when all patients in the studies were considered. The quality of evidence was considered moderate. While a benefit of PAP in adults with OSA and comorbid hypertension includes an improvement in blood pressure, the potential harms include side effects such as nasal dryness or irritation, dry mouth, sore throat, and sinus infection, as well as loss of intimacy, all of which can be mitigated with appropriate interventions or are reversible with discontinuation of PAP. The task force determined that the potential benefits of PAP therapy outweigh the potential harms and that the majority of well-informed patients would choose the intervention over no treatment. There is insufficient and inconclusive evidence to either recommend or withhold PAP to treat non-sleepy adults with OSA as a means to reduce the critical outcomes of cardiovascular events or mortality. This no recommendation is based on 17 studies, including 11 observational studies and 6 randomized controlled trials, that assess the impact of PAP therapy on cardiovascular events, and 13 studies, 9 observational studies, and 4 randomized controlled trials that assess the impact of PAP therapy on all-cause mortality. These studies demonstrated insufficient and inconclusive findings regarding the impact of PAP therapy on incident cardiovascular events and mortality. Therefore, no recommendation is made regarding the use of PAP based on reduced incident cardiovascular events and mortality. The quality of evidence for incident cardiovascular events and mortality range from very low to moderate. Some patients may place a high value on any intervention that potentially reduces cardiovascular risk, even when they are non-sleepy. In this situation, the patient and clinician should have a balanced discussion about the current state of the evidence about cardiovascular risk reduction with PAP therapy for OSA, and the potential harms of PAP therapy when there are no other indications to treat the patient's OSA. Recommendation 4 states, we recommend positive airway pressure therapy be initiated using either APAP at home or in-laboratory PAP titration in adults with OSA and no significant comorbidities. This is a strong recommendation. In-laboratory titration refers to both full-night and split-night titration. When APAP is initiated in the home setting, therapy is maintained over the long term by either using a fixed, continuous pressure setting determined from PAP monitoring data, or continuing in the auto-adjusting mode. Choice of PAP initiation in the home or lab should be based on access, cost-effectiveness, patient preference, sleep clinician judgment, and other factors. This recommendation is based on studies that excluded patients with the following comorbidities or conditions: congestive heart failure, chronic opiate use, significant lung disease such as chronic obstructive pulmonary disease, neuromuscular disease, history of uvula pallidopharyngoplasty, sleep-related oxygen requirements, or expectation for nocturnal arterial oxyhemoglobin desaturation due to conditions other than OSA, including hypoventilation syndromes and central sleep apnea syndromes. Finally, this recommendation is also based on the clinical trials reviewed, in which mask fittings and education on PAP use at a sleep center and/or close follow-up by trained staff during the treatment period were provided to the home APAP group. In some studies, daytime acclimatization to PAP was included. This recommendation was based on a meta-analysis of 10 studies that demonstrated no clinically significant differences in the critical outcomes of adherence, sleepiness, or quality of life between auto-adjusting PAP at home and in-laboratory PAP titration. The overall quality of evidence for this recommendation was high. Potential benefits of using auto-adjusting PAP in the home setting include lower cost, reduced time away from home, faster initiation of treatment, and greater access to care, whereas the potential harms may include inadequate patient education and the inability to identify and rectify problems related to mask fit, leak, or other PAP-related issues on the night of auto-adjusting PAP use. The potential benefits of an in-laboratory PAP titration include providing education by a trained sleep technologist, real-time visual identification of efficacy of therapy, and the ability to provide immediate interventions to make PAP treatment more comfortable for the patient, whereas the potential harms include the need for an overnight stay away from home at the testing facility, with the associated costs and patient time, and the potential delay in initiation of therapy. The task force concluded that the majority of well-informed adult patients with OSA and without significant comorbidities would prefer initiation of PAP using the most rapid, convenient, and cost-effective strategy. Recommendation 5 states, "We recommend that clinicians use either auto-adjusting PAP or continuous PAP for ongoing treatment of OSA in adults." This is a strong recommendation. This recommendation is based on studies that mostly excluded patients with the following comorbidities or conditions: congestive heart failure, chronic opiate use, significant lung disease, such as chronic obstructive pulmonary disease, neuromuscular disease, history of uvula pallidopharyngoplasty, sleep-related oxygen requirements, or expectation of nocturnal arterial oxyhemoglobin desaturation due to conditions other than OSA, including hypoventilation syndromes and central sleep apnea syndromes. This recommendation is based on evidence from 26 studies that investigated the effects of ongoing treatment with auto-adjusting PAP compared with fixed continuous PAP. Meta-analysis of these studies demonstrated no clinically significant differences between auto-adjusting PAP versus continuous PAP in the critical outcomes of adherence, self-reported and objective sleepiness, or quality of life. The overall quality of evidence for the use of either auto-adjusting PAP or continuous PAP was moderate. The task force judged that the benefits and harms of auto-adjusting PAP and continuous PAP are similar, and the balance of effects does not favor either intervention. The main potential benefit of auto-adjusting PAP to patients is the ability to automatically adjust pressure requirements over time in response to acute and chronic changes, for example, alcohol consumption, body position, or weight changes. No substantial differences and harms were identified for auto-adjusting PAP versus continuous PAP use. The task force determined that individual patient tolerance of PAP, adherence, and symptom response may differ for one form of PAP or the other, but that the majority of patients would choose either auto-adjusting PAP or continuous PAP over no treatment. Recommendation 6 states, "We suggest that clinicians use continuous PAP or auto-adjusting PAP over bi-level PAP in the routine treatment of OSA in adults." This is a conditional recommendation. This recommendation is based on BPAP defined as a respiratory assist device that delivers inspiratory and expiratory positive airway pressure. This recommendation applies to all BPAP devices, including flexible, modified, and auto-adjusting BPAP. BPAP devices may need to be used for patients with higher therapeutic pressure requirements than can be provided by CPAP or APAP devices. The decision to use BPAP should be based on the clinician's judgment and needs of the individual patient. This recommendation is for the initial treatment of OSA and does not address management of patients who have previously failed CPAP or APAP. The treatment of other forms of sleep-related breathing disorders associated with hypercapnia, which may require the use of BPAP, are covered in other AASM guidelines. This recommendation is based on 5 studies that compared the use of bilevel PAP to continuous PAP for improvement in the critical outcomes of adherence, sleepiness, and quality of life. Meta-analysis of these studies demonstrated no clinically significant differences in adherence, self-reported sleepiness, and residual OSA with bilevel PAP compared to continuous PAP. Meta-analysis of studies reporting on sleep-related quality of life and sleep quality also demonstrated no clinically significant differences. The overall quality of evidence was very low. The main potential benefit of bilevel PAP over continuous PAP or auto-adjusting PAP is improved comfort by lowering the pressure during exhalation, which may then increase adherence. The potential harms of bilevel PAP over continuous PAP or auto-adjusting PAP are a suboptimally low expiratory pressure level that fails to prevent the occurrence of obstructive breathing events and the higher cost of bilevel PAP. The task force also determined that the majority of adult patients with OSA would prefer initiation of treatment with continuous PAP or auto-adjusting PAP over bilevel PAP. Recommendation 7 states, "We recommend that educational interventions be given prior to initiation of PAP therapy in adults with OSA." This is a strong recommendation. Educational interventions include those focused primarily on providing information prior to initiation of PAP about what OSA is, its downstream consequences, what PAP therapy is, and the potential benefits of PAP therapy. This recommendation was based on 7 studies that evaluated the use of an educational intervention as an adjunct to initiation of PAP therapy, compared to PAP therapy with usual care for the improvement in the critical outcome of PAP adherence. Meta-analysis of these studies demonstrated a clinically significant improvement in PAP adherence with educational interventions. The overall quality of evidence was moderate. The potential harms of each of these interventions are minimal. The potential burdens to the patient are negligible for educational interventions. The task force judged that the benefits of educational interventions outweigh potential harms and burdens, and that the vast majority of well-informed adult patients with OSA would prefer that an educational intervention be provided with initiation of PAP therapy over initiation of PAP without education. Recommendation 8 states, "We suggest that behavioral and/or troubleshooting interventions be given during the initial period of PAP therapy in adults with OSA." This is a conditional recommendation. Behavioral interventions include those focused on behavior change prior to and during the initiation and subsequent use of PAP therapy, using strategies such as cognitive behavioral therapy or motivational enhancement. Troubleshooting interventions include those focused on close patient communication to identify PAP-related problems and to initiate potential solutions during the initial period of PAP therapy. The intervention period may include interactions prior to, during, and after PAP titration and follow-up. This recommendation was based on 6 studies that compared a behavioral intervention versus usual care, and 9 studies that compared troubleshooting with education intervention versus usual care for the improvement in the critical outcome of PAP adherence. Meta-analysis of these studies demonstrated a clinically significant improvement in PAP adherence with behavioral and/or troubleshooting interventions. The overall quality of evidence was moderate. The potential burdens to the patient include the time required to receive the intervention and the cost of the additional care for the more intensive behavioral and troubleshooting interventions. The task force judged that the benefits of behavioral and troubleshooting interventions likely outweigh the potential harms and burdens in most patients. In addition, the task force concluded that the majority of well-informed adult patients with OSA would likely prefer that a behavioral and/or troubleshooting intervention be given during the initial period of PAP therapy over no such intervention. Recommendation 9 states, "We suggest that clinicians use telemonitoring guided interventions during the initial period of PAP therapy in adults with OSA. This is a conditional recommendation." Telemonitoring includes the remote monitoring of PAP parameters, such as PAP use, residual OSA severity, unintentional mask leaks, and PAP settings during treatment initiation and follow-up. This recommendation is based on 5 studies that evaluated the use of remote monitoring of PAP variables to trigger early interventions versus no such system as an adjunct to PAP therapy. The critical outcomes include adherence, sleepiness, and side effects. Meta-analyses of these studies demonstrated a clinically significant improvement in adherence, but not in sleepiness, with use of telemonitoring. PAP-associated side effect severity scores tended to be lower with a telemonitoring guided intervention. However, these differences were not clinically significant. The quality of evidence was moderate. The potential harms of remote monitoring interventions are small, primarily related to potential loss of privacy. How telemonitoring guided interventions are implemented could lead to substantial increases in costs to healthcare systems, or conversely, may reduce costs if reductions in healthcare utilization substantially offset the investment in telemonitoring systems. Nevertheless, the task force determined that the benefits of telemonitoring guided adherence interventions likely outweigh the potential harms and burdens in most patients. The task force concluded that the majority of well-informed adult patients with OSA would prefer enrollment in such a system compared to treatment without such an intervention. When implementing the recommendations in this guideline, clinicians should consider strategies that will maximize the individual patient's comfort and adherence. The task force performed a systematic review of several interventions that aim to improve comfort and adherence, including modified pressure profile, mask interfaces, and humidification. Many PAP devices have now integrated modified pressure profiles, which lower the treatment pressure used during expiration. The potential benefit of using modified pressure profile PAP is increased patient comfort, while the potential harms of modified pressure profile PAP are similar to standard PAP. Appropriate mask selection may benefit patients by reducing side effects such as air leak and discomfort, which may then potentially improve adherence and subsequently patient outcomes. Lastly, the use of humidification could also potentially reduce side effects from PAP therapy. Studies suggest that clinicians should generally use heated humidification with PAP devices to reduce side effects that may occur while treating adults with OSA. In summary, 4 recommendations are strongly suggested and include using PAP to treat excessive sleepiness, initiating PAP therapy with either APAP at home or in-laboratory CPAP titration, continuing PAP therapy for OSA with either CPAP or APAP, and using educational interventions to initiate PAP therapy in adults with OSA. All other recommendations were conditional and include using PAP to treat impaired sleep-related quality of life or concomitant hypertension, implementing CPAP or APAP over BPAP in the routine treatment of OSA, and utilizing behavioral, troubleshooting, and telemonitoring interventions during the initial period of PAP therapy. When implementing the recommendations, providers should consider additional strategies that will maximize the individual patient's comfort and adherence, such as selecting a nasal, intranasal, over, or a nasal mask interface, and using heated humidification. To read the full text of this clinical guideline, or to download a guideline and a glance summary, visit the Clinical Resources section of the Academy website at aasm.org.